Good morning, everyone. Welcome. My name is Rod Liu, and I'm the Executive Director of APPEAL, Asian Pacific Partners for Empowerment, Advocacy, and Leadership. Thank you so much for coming today to join us in launching a unique and innovative program called ADEPT. Today we come before you as a collective from 7 different communities or priority population groups: the African American, American Indian, Asian American, Native Hawaiian Pacific Islander, Latino, lesbian, gay, bisexual, transgender, and low socioeconomic status or low SES communities, to say that we can no longer stand by while our communities are being left behind. Recently, California Department of Public Health announced that smoking prevalence had dropped below 12%, making it only the 2nd state in our country to do so. However, there are many populations here in California that have not shared in the gains reaped from California's tobacco control efforts. Diverse and vulnerable populations face some of the greatest disparities related to tobacco use. This is represented by high smoking and tobacco prevalence, a high number of deaths related to tobacco-related diseases such as lung cancer and heart disease, and in many cases, greater exposure to secondhand smoke. The tobacco industry has had a long history of predatory marketing directed towards our communities with specific cigarette brands, by funding cultural events, and cultivating relationships with our community organizations, all resulting in the inundation of our communities by tobacco. And with reduced funding for priority populations for tobacco control, many of our communities continue to lag behind the mainstream. Helping to increase our community's understanding of tobacco, the impact on vulnerable populations will lead to increased mobilization of tobacco control programs and policy initiatives. And this is why we are here today to launch ADEPT, which stands for Advocacy and Data Dissemination to Achieve Equity for Priority Populations on Tobacco. ADEPT is funded by the Tobacco-Related Disease Research Program of California and is a collaborative working to share and disseminate important tobacco data on our priority populations within our communities and with the mainstream. While tobacco control policies in California have been successful, we are concerned about the differential impact of policy and about our communities not always being fully involved in these policy efforts. But despite this situation of certain communities being left behind, there are inspiring examples that do exist of what we can achieve when we come together. Policies and programming initiated by our communities and for our communities can indeed be powerful. We need to be part of the solution. We are here today as examples of communities working together, not only for this project, but also in sharing the presentation of the impact of tobacco on our communities. We are coming together as the ADEPT Collaborative to help ensure that no communities are left behind and that lives are saved. I would now like to introduce Dr. Lourdes Baez-Conde-Garbinati from the Department of Medicine at the University of Southern California.
Good morning. Thank you for coming. I'm going to speak a little bit about the prevalence rates in our various communities. Smoking prevalence for American Indians has been reported as high as 24%. This is actually twice the rate of what's reported in the general population. And we need to be mindful that for American Indians, the way that tobacco is used in their community is in a sacred way. And so in many ways what we have seen is the commercial use of tobacco that has been quite detrimental, not just for this community, but for all of our communities. Data for Pacific Islanders, for example, ranges between 30 to 50%. And among Southeast Asian American males, smoking rates are as high as up to 70% in the population. Among young adults between the ages of 18 to 24, smoking rates have dropped to about 12%. However, in the lesbian, gay, bisexual, and transgender community, young adults smoke at a rate of 43%. Smoking prevalence for lesbian and bisexual women is as high as 32%, when the average rate for women in California is only 9%. So you can imagine the tremendous disparity that has happened in this population. The picture becomes even more complex when we look at national data. People with incomes below the poverty level are nearly twice as likely to smoke at 36%. The smoking prevalence is even more elevated among the homeless, who smoke at a rate of 73%. Smoking rates among the incarcerated range between 60 to 80%. The Centers for Disease Control reports that more than 3/4, over 77% of African Americans who smoke menthol cigarettes. African American men, for example, have the highest lung cancer mortality of any group at 81% compared to mortality among 54% in the white male population. Latino men and women overall tend to smoke fewer cigarettes than some other groups. However, contradictory to this, they are still one of the groups that's most exposed to secondhand smoke, especially in the workplace. This is especially true among our people working in the service industry. Among Latinos in California, those smoking at 16%, this smoking may become substantially higher in time, because already we represent 37% of the population and continue to grow at a very accelerated rate. What does all this mean? What this prevalence means is that tobacco, which is a modifiable risk factor, and it is one of the most preventable causes of death and disease, each year causes more deaths than HIV, illegal drugs, alcohol, motor injuries, suicide, and murders combined. So with these rates, I would like to now introduce to you Lisa Houston from the Break Free Alliance at the Health Education Council. Thank you.
Thank you, Lourdes. The tobacco industry has a long history of marketing directly to our communities. In 1971, an R.J. Reynolds executive put it this way: "We don't smoke that stuff. We reserve the right to smoke for the young, the poor, the black, and the stupid." They've targeted Hispanics and Latinos with cigarette brands such as Rio and Dorado, American Indians and Alaska Natives with American Spirit cigarettes, and African Americans with brands like Kool and Newport. The tobacco industry has tried to build its credibility in our communities by funding cultural events and donating money to population-specific causes. It's funded pride marches and powwows, supported Hispanic scholarship programs, given money to African American leadership groups, and LGBT elected officials, and enlisted Asian retailers in promoting tobacco products to all groups. They've also cultivated relationships with organizations serving the homeless and the mentally ill, and given away free cigarettes to clients of those organizations. FDA regulation will help curb the marketing of tobacco, but the tobacco industry has responded by marketing new products to our communities, such as little cigars and cigarillos. These two products have seen a dramatic increase in sales over the past 10 years. Between 1997 and 2007, little cigar sales increased by 240%, while cigarillo sales increased by almost 150%. Cigars, such as you'll see over here, are not yet regulated by the FDA. They're not subject to the same legal restrictions on marketing, advertising, flavorings, and product placements as cigarettes. They're more appealing to youth because they are, in general, significantly less expensive than cigarettes and are available in flavors like vanilla, grape, and cherry. In fact, several studies indicate that cigars and little cigars and cigarillos have become popular among the young adult population. And while it was in the 1970s that the Philip Morris Tobacco Company said, "Young blacks have found their thing, it's menthol in general, and Kool in particular," and Lorillard said that the base of our business is the high school student, it's clear that Big Tobacco's viewpoint on these populations hasn't changed. A recent study by the Stanford Prevention Research Center shows that tobacco companies increased the advertising and lowered the sale price of menthol cigarettes at stores near California high schools with larger populations of African American students. You know the tobacco industry targets our communities, and the truth is that the tobacco industry targeting is not limited to vulnerable populations. They also target mainstream communities. But vulnerable populations are in much less of a position to defend themselves. Our communities have had many more issues to deal with and less capacity and resources to deal with them. Our communities are fighting violence, high unemployment, HIV/AIDS, and the list goes on. So while the tobacco industry targets our communities, it's much more detrimental. And with that, I would like to introduce Carol Magruder from the African American Tobacco Control Leadership Council.
Thank you, Lisa. Good morning, everybody. I'm going to be talking about policy and how policy affects our different communities in different ways. A primary and effective arm of California's comprehensive tobacco control strategy was the introduction and adoption and implementation of public policies that contribute and reinforce communal social norm changes. Social norm changes entail creating community environments that support healthy lifestyle behaviors and discourage the unhealthy ones. From clean indoor air laws to preventing underage access to tobacco, our state has been a model for changing norms around smoking. Unfortunately, and for many complex reasons, the communities who are the most disproportionately affected by tobacco use are usually the last communities to reap the benefits from public health policies. And there are many different reasons why those benefits just tend to trickle down to very slowly to the folks who need them the most. We have competing priorities in our communities, as Lisa just talked about. Many of us are working on different issues. Dr. Biasconde Gabernati works on obesity and tobacco. I work on AIDS, tobacco, black infant mortality. So our communities are stretched, and the people who are charged with protecting the health of those communities are also stretched across different domains. The tobacco industry has been very savvy at tailoring their predatory activities toward our individual communities. And we in the public health arena can learn a lot from them. And while it's not practical to tailor specific policies for each community, we can do a lot more about educating our communities about the importance of effective policy implementation. And we can be a lot more inclusive when we're drafting the policies initially so that they do benefit the communities, the different issues that face different communities and they're broader. When we talk about low SES, and as we talk about our different party populations, they're not distinct groups. In the low SES group, you have a lot of African Americans, you have a lot of Latinos. In the LGBT community, you have all the different communities that make up the world in those groups, so there's overlap. In California, we've had smoke-free laws for a long time, but 1 in 7 California workers still do not have a smoke-free workplace due to loopholes in the current legislation. And most of those people are people who work in blue-collar employment, hotel lobbies, banquet rooms, warehouses, owner-operated businesses, long-term health facilities, and licensed family daycare homes. And many of those people are people of color. And these are the people who are at the increased risk for lung cancer, for heart disease and respiratory diseases. They have less control over their working conditions. They have less, their health care coverage, if they have it, is less comprehensive. They don't benefit many times from nicotine replacement therapies or cessation treatments. And so the least that we can do is to make sure they're protected by the same policies and laws that protect all Californians. When we talk about low SES smokers and price, there are many groups that say that tobacco taxes are regressive for poorer populations, that it makes them spend a higher percentage of their income on cigarettes. But when we raise the price, we know that more poor people will stop smoking because they are price sensitive. And then we also need to have policies that a lot more of that money that's taken in from cigarette taxes to help the populations who are most at risk and burden. In talking about policies in the LGBT community, while 55% of California men were advised by a healthcare physician or professional to quit smoking, only 41% of gay and bisexual men were similarly advised. And with women, it was 60% of California women, and only 51% of lesbian and bisexual women were similarly advised. And sometimes that's about a lower expectation for different communities that they're going to follow advice or that they're going to change their behavior. But all of our communities need to be receiving the same health messages from our health professionals and practitioners. When we talk about exposure to secondhand smoke in the home, when you look at the Asian American community in the aggregate as a whole, it looks like they're doing fantastic. But if we take out Chinese American or Filipino American, we know that their men are smoking more and that there's more smoking in the home. And so those families, the women and children, are then more at risk for diseases that are related to secondhand tobacco smoke. And we need to do more with those communities to educate